We would now like to invite our other panelists to join Kathleen and Joanna on stage. Lindsay Videnieks, Executive Director of the Headache and Migraine Policy Forum, Julienne Verdi, Executive Director of the Alliance for Headache Disorders and Advocacy, and Katie Moran, Volunteer and Support Group Director of Miles for Migraine.
Thank you, ladies, for joining us. Julienne, I'd like to start with you. Your organization is hosting Headache on the Hill today. So tell us about that, what you're trying to accomplish, and what legislation is affecting the headache community is AHDA most interested in seeing get passed?
Yeah, so today's a really exciting day. It is our first biannual Headache on the Hill. So we offer this twice a year, in person in the spring and then virtually in the fall. So we have about 175 advocates from 40 states conducting about 200 meetings today with their members of Congress. And these are patients, medical providers, caregivers, researchers, all united under this common goal of making life better for the over 40 million Americans living with headache disorders. These are all volunteers. They applied to be part of this cohort. They went through extensive training on everything from how a bill becomes a law to how to tell their personal headache story, how to get their story told by the press, and even how to use social media as an advocacy tool. So they've been working really hard, and they're going out into the world today to try to make a difference. So we have three main things that we are advocating for during this Headache on the Hill. The first is the Safe Step Act, and we heard a little bit with Dr. Alani talking about step therapy and how that really impacts our patient population. So this is probably the thing that we've been working on really the hardest this year, is to try to get the Safe Step Act over the finish line before the end of the year. What this would do would be to create an exceptions process to step therapy protocols. We know that headache disorder patients are some of the most impacted by these protocols. And when headache patients aren't treated appropriately, they can move from episodic to chronic. So their conditions get worse and worse. And so this exception process would take it would be between 24 and 72 hours, where the insurance company for employer-sponsored plans would have to respond and hopefully grant exceptions to those processes. So that's one. Two, we're advocating for the Advancing Research for Chronic Pain Act. And this is a bill that would require the CDC to collect, publish, and analyze population health data on chronic pain. And as you heard earlier, this is a disease state that is chronically underfunded. And so having better data on the amount of people that are impacted by headache disorders, we know that that's going to help us move the needle forward to get the amount of funding this disease state so desperately deserves. And then finally, the last bill that we're advocating for is the Connect for Health Act. And this would make
telehealth, right?
Yes, yes, exactly. So this would make permanent the telehealth Medicare flexibilities that were implemented during the COVID-19 pandemic.
And why is that important for this group?
So we, as you heard earlier, we have a real shortage of certified headache specialists in this country. And so the waiting list to get in to see these specialists is incredibly long. So anything that we can do to expand access to providers that understand the complexities of headache disorders, we've got to do it. And we know that headache patients in particular, right, if I'm in the middle of a migraine attack myself, it's very hard for me to drive. It's probably not safe for me to drive in those moments, right? Because I'm having visual disturbances and things like that. But light sensitivity, sound sensitivity, it makes it hard to go into a doctor's room with the bright lights and all of that. So telehealth has been such an important piece of headache care for so many patients, and we need to make sure that we maintain that.
Thank you. Lindsay, the Headache and Migraine Policy Forum, I think, has done some really fantastic research in this area of migraine. Could you share with us some of the most important data that people may not know? For instance, what are the direct and the indirect costs of headache disorders?
Yes, thank you so much, and thanks for having us. So, this group heard from Dr. Alani, I think, talking earlier a little bit about these cost containment measures. So, when migraine patients seek care and treatment, they're sometimes faced with the stiffest of utilization management protocols, right? So that could be prior authorization, step therapy, as Julienne talked about. HMPF did a claims data analysis in 2019 of 1.2 million claims of commercially insured migraine patients, to just sort of better understand, there's a pharmacy benefit and a medical benefit that, patients can avail themselves of with their individual plans. Our study showed that when folks are mismanaged or not provided access to treatment on the pharmacy benefit side, they ended up actually spending a lot more money on the medical benefit side. So what would be a cost containment measure ends up being more expensive, both for the patients and the healthcare system at large, because you have this revolving door of migraine patients who are being mismanaged, undertreated, ending up in the ER. The fourth highest users of the ER is the migraine patient population. And so as you can imagine, the stress and burden, Julienne talked about bright lights. There are no brighter lights than if you're going to an emergency room in distress, having to pay that copay, and then you're losing time from work. So I will also say that our study showed, not shockingly, an exacerbated effect among communities of color. So Black patients, 24% higher rates of ER visits when not provided access to treatment. Hispanic patients, 18.6% higher. And so if you can think through all of the social determinants of health that make it difficult to get treated in the first place, the neurodeserts like Julienne talked about, lack of access to a provider, and then how that pulls through when you end up having to go to the ER, it's just layers upon financial stress and burden for patients.
Katie, tell us about Miles for Migraine. How did it all start and what are its goals?
Well, Miles for Migraine started way back in 2007. One woman came actually here to Washington, D.C. She and her daughter had migraine, and she wanted to talk to Congress about migraine and helping to get funding for migraine. And she realized that Congress had no idea what migraine was. And so she got on the airplane, she was from San Francisco, got on the airplane, flew back and said, they don't get it. I need to do something more for migraine. So she started the very first Run, Walk, Relax event in San Francisco at Golden Gate Park, and that's how Miles for Migraine started. And today we have 24 Run, Walk, Relax events all over the country every year. And the money that we raise at our events go to headache centers that train fellows for become headache specialists. So that's what the money goes towards for our events. It doesn't go to Miles for Migraine. It goes to train new headache fellows. As you've heard, there's a shortage. So that's what the money goes towards.
So it's interesting. It sounds like the person who founded your organization is very similar to all of you on stage. It's personal experience with this disease that motivates you. I'd love for any of you to kind of talk about that and how it got you involved in what you're doing right now and how personally important that is. Just jump in, anyone.
Well, I can talk. So I'm pretty much the only sociologist who's been working in migraine. There's luckily some new voices coming in for over 20 years. And in health and medicine, this is extremely unusual. And part of this is because there is very little survey data in migraine. Again, extremely unusual for a disease this prevalent for surveys to not include questions unless they are coming from the headache world. So I just want to preface it by saying that. So why would I have done this? Well, I wanted to, 20 years ago when I was, well, unfortunately it's longer than that now, when I was a graduate student and I wanted to study bias in medicine, gender bias in medicine, I was like, oh, you know what, I've experienced that. And I was interested in gaps in medicine, things medicine didn't understand. And you know how I know that is because every time I went to a doctor, they told me I didn't have the thing I had. They kept saying, you know, you seem fine. And it turns out that following sick patients, and when I talk to sick patients, they are very good at telling me what doctors don't know. And it's been an extremely good research method for me to just listen to patients. It turns out to be a very good thing for doctors to do as well, right? That's a great way to learn where you need to do more research. And migraine, and usually sociologists change their topic. Unfortunately, there's so much work to do in this area that I keep getting pulled into headache medicine. So it's just been very, very fruitful for me. And I would say that that's for the worse for headache medicine. There's just too much to do.
Julienne and Lindsay, I see a lot of head nodding. Yes. Familiar.
Yes. Well, for me, my best friend lives with migraine. When we were roommates, she, I remember everything having to be a darkened room, nausea. She would have to miss work. She actually was a top performing lobbyist in DC, had to leave that field entirely because she simply couldn't do her job. There was no reasonable accommodation that could be met for her to do her position. My daughter has experienced episodic migraine attacks, and I'm been speaking with folks in our community about what that means on a pediatric level. But there's someone, I would gather that everyone in this room, folks watching, someone living with migraine disease or affected by it. When you do Capitol Hill visits, Julienne, how often do staff say to you, raise their hands? So I think it's very common to have that experience.
Yeah, so I think, thank you for that. And one of the ways that we encourage our advocates to start their meetings is to ask the staffer that they're meeting with or the member of Congress to say, do you or anyone you know live with a headache disorder like migraine? And the responses that we get, and we record those, and it's really good data to have. And it's sort of a two-sided coin. Sometimes they'll say, yeah, my mom gets headaches sometimes. She used to just take a few Tylenol and go lay in a dark room and then be fine, right? And then other people will say stories where they'll talk about someone they know or they themselves being incredibly disabled by these conditions. And so no matter what the answer is, it's a great segue into a personal story to tell, how does this impact someone's specific life. So what I always say to our advocates is, if statistics alone were enough to change hearts and minds, the Alliance for Headache Disorders Advocacy wouldn't exist, because we know we have that on our side. That's not what's going to move the needle. It's the personal stories. It's showing how this impacts real people that we're going to make a difference. So I'm someone who lives with migraine, and I'm also the parent of a 9-year-old child living with migraine as well. So that's what we do. We talk about how this impacts us on such a visceral, personal level, right? So when I have a migraine attack, and this has happened in congressional meetings before, where I'm having an attack, and I use it as a teaching tool, right? So one of the things that happens when I have an attack is occasionally I have something called aphasia, where I lose the ability to really have my words come freely out of my mouth. I lose the ability to communicate. And I'll say that, I'm having trouble finding my words right now. I'm in the middle of a migraine attack. I can feel it starting. And if I don't treat it right now, I'm going to get really sick, right? I will be nauseous to the point of vomiting.
So do you get up and leave the room?
No, I'll take my medication and explain what's going on. I think that's how we're going to change things, by showing people what this looks like. It's such an invisible disease. It's something that we talk about. You can look at someone, you might not know what they're going through. And so we have to make that invisible thing visible to them.
And Katie, I think it's important also for people to understand that migraine can be caused by a treatment for another disease, because that's what happened in your case, correct?
Yes. So a lot of times, in most cases, migraine is a hereditary disease. For me, my story is a little bit different. In 2006, I had a very rare cancer that was in my sinuses in my right eye. And luckily, I beat my cancer. But the radiation to my face, I was left with chronic migraine. So that led me down a totally different path. And I got very good treatment. When I had my cancer, after the radiation, I had a headache, a headache, and they kept saying, oh, it's a headache, it's from the trauma, it will go away. Well, about a year and a half after, they said, well, let's send you over to the headache center. So I went to the headache center, and I was quickly diagnosed with chronic daily migraine. My migraine was a 9/10, 24/7, 365. Oh. So when I went to the headache center, they said, oh, you have chronic migraine. So they switched all of my medications that I was on for pain from my cancer. And within about 3 months, my 9/10 headache went down to about a 7. And I was like, oh my gosh, like this is awesome. And in about 6 months, I got down to about a level 5, which is what I live with today, 24/7, 365. I'm about a level 5 migraine. And it gave me my life back. So we do tell people that migraine is not always hereditary. It can be from a car accident. It can be from another type of treatment.
COVID.
It can be from...
a lot of people with COVID are getting migraines.
Yes, a lot of people from COVID are getting migraine. They're left with a headache from COVID. So it's, there's another type of migraine. So.
You used the phrase a moment ago of Julienne, of the it being invisible, an invisible disease. Let's talk about that. What is that like to have a disease that most people, they don't see it, they say you look fine. How do we break through? How do we turn this around? Joanna, you want to take that?
So I may have a counterintuitive take on this, because I actually don't think migraine is as invisible as we think it is. I'm going to ask everybody on this panel, do the people who know and love you know when you have a migraine? Do you have to tell them?
That's true.
Mm-hmm. They know. When my daughter is getting a migraine, I know immediately because she goes like this. You can see it. You have to know how to look. And I think that that's a lot of what that's actually true of a lot of invisible diseases. It's what kind of evidence do we consider credible and real? And in migraine, there is so much evidence that somebody has migraine. There's so much evidence. First of all, they're telling you. They're telling you they can't work. They're telling you that they're in bed, but we're not believing them.
So true.
And so I kind of reject this idea of invisible disease, because people who have invisible diseases, you can see it if you want to see it.
Yes. Well, I think isn't there an education component here, because people don't know the symptoms that you just described?
Yeah, right? Well, we've educated them about brain scans.
No, it's true. It's true. Like, I'll turn the TV down, or I'll say, oh, there's too much noise in the room, and my husband, sorry, I think he's watching. My husband will say, oh my gosh, like this is annoying. Why can't I have music on while we're cooking dinner? And I'm just like, it's too much for me right now. And he's very educated about my migraine, but sometimes he just doesn't turn that switch on. Or why did you sleep so late today? Or you only made dinner 3 times this week. Things like that. And he knows I have migraine.
The one thing I would also add is that we have a lovely woman panel today. We don't have a manel, but at the same time we haven't talked about that purposeful stigma, I would say the warrior effect for veterans, and a lot of men who don't talk about living with migraine after a TBI, or because they think it's just a headache or it's a woman's disease. There's a lot of, we interact with veterans groups all the time that talk to us about, how it's just underreported. And Joanna, you probably know the statistics on this, but there's a lot of men who just don't talk about it.
Thank you so much for bringing that up, because migraine is so prevalent that 7 to 9% of men have migraine. That is a huge number of people for any disease to have. We talk about migraine as a women's
here
disease.
In the room have migraine?
Yeah,
I'm just curious. We have a show of hands. Okay, we have at least one.
So one.
Interesting.
Interesting. In terms of public stigma, so public stigma is like how the media talks about and writes about a disease. A migraine, there was just a recent study came out last year, and ranked out of 106 disease, Migraine was the most stigmatized chronic physical disease at the same, kind of attracted in news media, the same amount of stigma as chlamydia.
Wow.
And that seems surprising unless you've been doing this for 25 years, and then you're like, yeah, that sounds right. And it was especially stigmatizing around the ideas around moral character, discuss this idea around weakness. Now, I think that that's driven by this gendered, this idea of femininity, like that you just can't handle the pain. But think about those 7 to 9% of American men who have migraine. That affects them as well. So we're calling this a women's disease, but it's, in a lot of ways, it's a men's disease too. And it is, maybe counterintuitively again, easier for especially like white women, to get a diagnosis than men.
Yeah.
And men, again, we know men don't go seek help anyway.
Right. Well, right. So here we are saying it needs to be on the well-woman visit chart. But where does that leave men? Right.
Well,
right? If they're not asking women, will they? Well, never think of asking
it's not good for anyone.
No,
it's not good for anyone.
Miles
Julienne, okay, go ahead.
Miles for Migraine, we have support groups, all different support groups. We have a support group for men. And we have been working so hard to build that support group.
Is it the smallest of your support
groups? It's the smallest. Okay. It is. And we try. We have it out there. We have it on our social media. When we have our walks and runs, I always say, men get migraine too. Please join our support group. I even have the men raise their hands. And they do. They have migraine. But it just is, I think the stigma for men to join a support group is there too. Would you join a support group and talk about your migraine?
But they'll join support groups for PTSD and for TBI, and migraine is highly comorbid with both of those diseases.
Right.
So again, disentangling how much of this is the stigma around gender is important. But again, it's a stigma that's bad for everyone.
Julienne, what about your organization? How many men participate?
We certainly have a large contingent of our Headache on the Hill advocates who are men.
Yeah.
But I was also going to just say too that, and on a personal level, so my father has migraine. And it was not until I started doing this work that he even made the connection, or I helped him make the connection. So I remember, and this is part of why.
So you didn't know growing up.
So right. So, well, it's because he used to call them sinus headaches. So, and it's funny. So he used to, every morning I would see him with a cup of coffee on his face, like right here, and he'd hold it because the hot cup felt nice on his mind, because he'd get one-sided migraine, and so seeing him, I thought this was normal. I thought everybody, because I'm watching my father have this condition, I had this condition, I thought everybody got a headache every day. So it really wasn't until much later in life where, I was talking to folks and they were like, no, I don't get headaches. I'm like, what? I get one every day. What do you mean you don't get a headache? And I think that's where the education piece comes in. So when I'm talking to people, one of the things I say is you don't have to live like this, right? This does not have to be your baseline. And that's why it's so important to talk to your doctor about this, to get the care that you need. And so that's often what comes up when we're talking in Congress and we're speaking with legislators and their staff. Sometimes at the end of the meeting, I've had staff come up to me and say, hey, do you have a recommendation for a headache specialist? I think I might need one, right? After that meeting themselves, they've now self-diagnosed themselves and realized that they don't have to live like this and they should get the care that they need and deserve.
That's fascinating. I'm curious, the White House launched the Women's Health Research Initiative to address the disparate health experiences of women in America, and it provided concrete recommendations on the lack of research for conditions that do disproportionately impact women, and migraine is included. So are you optimistic after seeing that, and what more would you like to see on the federal level that's not being done right now for migraine disease?
Yes, I think if I could just jump in really quickly, you touched upon the Women's Well visit, and so I'd like to bring it back to that a little bit. So for those unaware, there's the U.S. Preventive Services Task Force, which recommends a lot of screeners for general health, but then also in women's health, in 2016, there's a group formed called the Women's Preventive Services Initiative, WPSI, WPSI. They are responsible for what goes on and off the Women's Well Visit screener. And so, migraine is currently, and headache is currently not on that list. And in some cases, if for many women, that's your only doctor's visit, right? Like, you're a sandwich generation person, you're taking care of others, you have littles, you have aging parents. That may be the one doctor you see in a year. And if you're not proactively asked about your migraine, are you going to talk about it? And in some cases, you're charged extra for bringing up topics in that visit that are not on the screener. So groups like ours are working together to try to figure out how we can help them understand the importance of adding that as a topic nomination.
What is the argument against that?
I think that, it's, number one, it's a limited amount of capacity for providers to have conversations. Every disease state would love to be included. It has to very clinically and scientifically meet a threshold. You have to prove that with evidence, and so we're working through a process. But, if you don't have that conversation starter, it's really hard to close that gap of underdiagnosis. So that would be something where, WPSI receives federal resourcing from HRSA and HHS, and we hope that we can work with them to see if there's a way to add migraine. Similar to anxiety and depression, they're on the screener. We think migraine should be too.
Thanks so much for bringing up the Women's Health Research Initiative, the White House Women's Health Research Initiative. So it was almost a year ago now where that was first announced, and we were thrilled when the announcement came out. Migraine was included in the initial announcement, and we see this as an excellent opportunity to move the needle for this disease state. So the Alliance for Headache Disorders Advocacy wrote a letter to the White House Women's Research Initiative. We had about 20 co-signers onto that letter, really outlining all the things that you've heard today, the differences in funding levels, right? We know that I think it's 10.8% of NIH's budget that goes towards women's health, right? And women make up 52% of the population, right? We've got to move the needle there. And then for headache disorders, it's even lower. It's 0.2%. And that's growing, and we're proud of the research that's being done, but we've got to continue to move the needle. And so we are hopeful that all this investment in women's health will have an effect on migraine. It's certainly what we're advocating for. I think it remains to be seen, though, if that's going to happen. And so, we need more researchers in this field seeing this as a worthy field to go into. We need them to apply for these grants, right? There's so many different things that we need to move the needle forward. But this, I think, really offers there's hope on the horizon, I think, to recognize that this is a condition that is worthy of attention.
And that's something being a volunteer at Headache on the Hill that we do throughout the year. Like, sometimes we'll get an email from Julienne and say, hey, can you send this letter to your state representatives to help us sign on to this ask. So it's being a volunteer for Headache on the Hill. It's not just a one-time thing. We can do things throughout the year. So while we volunteer for Headache on the Hill in March and today, we might do things throughout the year as well.
Joanna, do you have thoughts?
Yeah, so migraine, I think, it is really harmed by what I consider structural ignorance and a kind of cognitive ignorance, that it's not something that we think about as important. And then structurally, the production of ignorance is that policymakers it's not on their mind. They're not thinking about it. So all of these specific policies are an attempt to intervene there. More broadly, it would be really great if people started to actually consider migraine as this incredibly prevalent, disabling, costly disease that it is, and started doing things like say, hey, we should have a few questions about migraine in this national health survey, right? We should be really prioritizing doing something about this incredibly important pain disorder. And I think that would go a long way.
Do we need some public awareness campaigns? I feel like education is really critical here. And who should be doing that?
I think we absolutely need some public awareness campaigns. We're actually planning one. We're going to be doing an installation on the National Mall in June 2025, and that's exactly the point, is that, you know, headache disorders are too often ignored, and we want to make them impossible to ignore. So we're going to, you know, have 30,000 purple flags on the National Mall, and hopefully some a global effect. There's hopefully going to be some sister installations happening across the globe, and all to raise awareness that this is an issue. You don't have to live this way. We need to do better. Patients deserve access to the care they need when they need it. And that's only going to change if we have this be a sort of public, a better public awareness of what's going on. And we need to talk about it and, again, tell our stories, because by doing so, that's how we're going to change hearts and minds.
I was going to say, it starts with us. It's really important for all of us that have migraine to advocate for our disease, and it starts with telling our story. And at Miles for Migraine, we work really hard to teach everybody how to advocate for our disease. It's very, very stigmatized. It's invisible, so people are very afraid to talk about it and to tell their stories. But we teach them how to do that and to not be afraid. So,
in the interim, I know, let's talk about how we can help patients with these issues, say like access, because that is so critical. We've heard today there are, you know, millions of patients, but so few experts who are really trained to help them. So how let's start there. How do we fix that?
Yeah, I would just say on a very tactical level, you know, and for migraine patients, just imagine it. You get a denial letter in the mail, and you don't know if you wake up that day, if you can be on the phone with your insurer for 3 hours or whatever it takes to go through the phone tree of, you know, reaching a person who might try to attempt to understand your disease. There are these additional barriers, I think, for this patient population that are just more challenging, right? And so our organizations combined, I think, do a pretty good job of making sure that this is also, patients know that there are hotline resources, places they can go for sort of immediate help in navigating those insurance barriers, right? So I will say a lot of folks don't know that your state health insurance commissioner, every state has one, really serves within the Division of Consumer Affairs. If you hold insurance, that's a consumer product. You are paying for a benefit. If you are not receiving it and there's a systemic access challenge to it, you're entitled to file a complaint, a consumer complaint, with your state health insurance commissioner. And we've been told, most recently by the Florida State Health Insurance Commissioner, that's very helpful to them because they can serve as a liaison to payers, to insurance plans, to say, you know, great example, a certain plan in the state of Kansas was saying that migraine patients could only receive treatment from a UCNS certified headache specialist, of which there were 0 in the state.
In the entire state.
In the state. So, you know, that's not only an impossibility, but it's a problem that, you know, we worked with the state health insurance commissioner to ameliorate. And so you just have to help, maybe it's patient toolkits, you know, getting the word out on social media, you know, helping them understand they have resources to avail themselves of, and that they don't just have to sit with a letter of denial and do nothing with it.
And Katie, do people in your support groups talk about that they need to file these complaints?
Oh, yes. It's one of our hot topics in our support groups, yeah. And I actually just got denied last week for one of my medications that I've been taking for 3 months. So I got a denial from my insurance company. Oh, we don't think you need this medication. You can just use it, NSAID. And I actually was going in for my Botox that week. I took the letter to my doctor. We sat down and we tried to figure out, he said, I'll write a letter to get you back on that medication. And we actually switched some of my medications around and decided that I didn't need it. We moved them around. But it happens all the time. It's a big topic for the support groups. So, but also everybody should have a migraine toolbox, which should include not only medications, it should include mindfulness activities, it should include medical devices, It should include all different things. So if that should happen, you fight for your medication, but you also have other things to help you besides medication. So we teach that in our support groups and in Miles for Migraine as a whole. We have events, we have things like that, but we have things to help those that work with Miles for Migraine in their toolbox. It should be really full with all different things.
Yes,
So I think that there's some short-term fixes and long-term fixes, right? So on the short term, we want to empower patients to be their own advocates, to advocate for what they need. So whether it's insurance, going through the insurer complaints and going in that route, I think is incredibly important. And Lindsay's organization has some great resources. The other things that we've taught our patients to do are use constituent services. So we've had patients who've had really good luck with contacting their governor's office, contacting their member of Congress and explaining the issue, and their constituent services getting involved to solve the issue. We've had lots of patients who've been able to bypass the step therapy protocols by just getting their elected officials involved. And I think that there's a two-pronged issue here, right? One, you're raising awareness, right, with the office, and so you're hopefully building a champion within that office themselves, and obviously you're getting the patient the care they need. The other thing that we've done is, talk to medical providers about how to navigate the process to help their patients. It's incredibly time consuming for medical providers to go through these processes. And
then that's just what I was thinking. And as it is, we're talking about the fact that there are so few of them
right,
to make the demand.
Yes,
so they have all these patients who want to get in to see them, and now they have to spend extra time writing these letters and fighting this battle.
Yep. So often what we've taught them, what we suggested they do, some of our doctors have some really good success with this, is they get on the phone and they say when they do the peer review with the insurer provided doctor, they say, what's your specialty, when's the last time you've practiced, and what's your medical license number. I can't tell you how many times that alone all of a sudden the step therapy protocol goes away, because what's happening is that insurer provided doctor doesn't know anything about headache medicine, right? And that is something. And then the last piece, when I'm talking about like the short term and the long term, we have to fix our laws. We have to pass the Safe Step Act. We have to have a clear exceptions process so that patients can get access to the care they need when they need it, instead of allowing insurers to decide that what they know best for a specific patient.
And that would again help patients not just with migraine, but with any disease.
Absolutely, absolutely, and so many different chronic. And then I'll also say that a lot of patients, headache patients, have lots of comorbidities. So they're dealing with this on every single lens. Like I'm someone with a comorbidity, and I have to deal with step therapy protocols for my migraine medications as well as all the other medications. It's a full-time job being a patient with a chronic health condition, and the effects on our economy are enormous. So this is it's not just good science and good medical practice, but it's good for the economy.
Right. And what happens a lot of times.
Okay. Let's switch and then we'll bring.
Yeah, go ahead.
Okay, so I wanted to a little bit piggyback on what Julienne was saying, which is so important, which is we're asking patients to do a lot of work and advocacy.
We really are.
And that is only going to be available to our best resourced patients, that not only who have the knowledge, but who have the time, the ability, and who have physicians who are willing to do that work. It's very hard sometimes just to get your physician to call in a prescription, let alone call in an insurance company. So this is really, in a way, even perpetuating inequality. And so it is absolutely vital that we do all the work that we can do to put this into legislation, to put it into policy, and to work on population level interventions here. We know that migraine is more prevalent as you go down the socioeconomic ladder. And this is not just social drift. This is not just because people are making less money and are on disability. We don't have enough research on what's going on there. But again, the most marginalized people, the least resourced people, are the people who are going to be most impacted by migraine, least able to access medicine. And the one thing I've learned in my decades of doing research on migraine and studying migraine patients is that we are losing so much creativity, so much innovation, so much vitality because people are not able to go about their life. They're not able to go to work. They're not able to take care of their families. My children see me in bed most of the time. You know, when I did do a song and dance about how much I do, but most of the time I'm in bed. That's how I work in bed. That's how I do my job. And what we lose in the United States because of this disease is so huge. And that, I think, is invisible.
It's a real public health burden, you're saying.
It's the public health burden, and I can't imagine how transformative it would be if we could capture all of that energy. It would be amazing.
Katie.
And what I was going to say is what happens when insurance companies do this is someone that might be episodic in migraine, it could take them to chronic. And so that's just then a whole other burden in this migraine disease. So again, another reason.
And if I could just add one more thing, and then when patients are getting sicker and they're in this much pain, we have an issue of suicidal ideation in this community.
Yeah, we really
and
do.
when you're not able to access the care and you're living in just immense amount of pain and suffering in silence, that is a huge problem, and it's something that's not talked about enough.
Do you have statistics on that? How many?
So I don't have the exact statistic right now, but I have the anecdotal stories and the stories of these beautiful lives cut short that it doesn't have to be this way if they're able to access the care they need and so desperately deserve.
And I think that, you know, from our perspective and just looking at the claims data, but hearing what Joanna and Katie and Julienne said, it costs a lot to mismanage this disease, right? The financial and all of the costs, not just financial, but the burden, it's just a tremendous waste of energy and effort and talent and all of the things that could be contributed. But it's very expensive to not treat, if that makes sense.
$20 billion a year is what the estimate is that migraine costs the economy. $20 billion a year in the U.S.
I'm sorry, but we don't have good numbers on suicidal ideation and suicide attempts or suicide. I mean, it's very hard to measure anyway. And again, I keep harping on surveys, but I know that in my family, my mother's told me about a cousin who did kill themselves because of migraine many years ago before I was born. And I think that that's true in a lot of families, that they know people. It's very demoralizing to live with chronic migraine. It's a, you know, yes, depression is comorbid, but it's very, very difficult. It's a very difficult life. You need a lot of support, and it's difficult on your caregivers.
And that's what we have just under a minute. If you could share any thoughts you have for how those in the room or those watching, how they can advocate for support people living with migraine disease.
Yeah, I can say one thing for me. When I found Miles for Migraine 6 years ago, we're talking about this suicide and this loneliness. 6 years ago, I found Miles for Migraine by going to my first walk. I live in Delaware, and I went to the Philadelphia event. And there were 700 people there back then. We hoped to have 1,000 on Sunday as our walk. I had great care. It was myself and my headache specialist. There were 700 people there, and I finally was not alone. I couldn't believe all these people that had migraine. And so that Monday, I called the executive director, Shirley Kessel, and I said, what can I do to help? I want to help these people. I want to do something. I'm not working. I need something to do. And she said, can you work for Miles for Migraine? And I said, I can't work, I have migraine. She said, yes, you can. And so I started to work with Miles for Migraine. I worked part-time. I finally had my life back. I was finally able to give back. I finally felt like a person again. And at Miles for Migraine, our support groups, you're not alone anymore. People come to our group, they thank me for what I do, and I thank them for what they do, for coming to the groups, for being vulnerable, for telling their stories, for sharing. And just like we were talking about, they are no longer alone, and they now have a community where they can come to and not be alone anymore. And I think that the support that we give them makes them finally not alone. And yeah, so
Julienne,
that's what I'll share.
Quick, briefly.
Yeah,
what
so
would you
I'll
advise?
just, one, come to Headache on the Hill or support Headache on the Hill. There are ways that you can be involved from home, so find us on social media and all those things. But the other thing I'll just say is believe people when they say they have a migraine and they can't come. Don't give them a hard time. That's like the number one thing that you can do. If I'm saying I don't feel well, ask what's going on. What can you do to help? Right? I think, again, that's, engage in a conversation. Be interested to know how, if someone's telling you they have a migraine, what does that mean for them? What are you experiencing? Ask questions. Learn about this disease state. And then be a part of making change. There's a doctor who actually says that he prescribes advocacy to his patients, because when patients are actively involved in their care and advocating for change, that gives people hope.
Agency.
We hope that more people come to Headache on the Hill. We're going to open up applications for our spring event in November. It'll be March 17th and 18th in DC. Come be a part of this community, and let's speak truth to power and make change for the 40 million Americans living with this condition.
I would just say very succinctly, you heard that we need to talk about. It's not invisible anymore. People, you can tell. Know that you have people on your side. So you have people doing big things, but you also have folks who are there to help support individual patients in these very tactical state level issues with insurers. Know that you're not alone. And to Katie's point, you have a lot of folks who are just like you and who are also willing to help you.
Joanna, Katie, Julienne, Lindsay, thank you so much for such a great discussion. And thank you all for joining us. I think we have final words.
Thank you, Kathleen and panelists. That brings us to the end of our program. Thanks to all of our wonderful speakers this morning. On behalf of The Hill and our sponsor, Pfizer Medical Affairs, we'd like to thank everyone who joined us here in person and those of you who tuned in online. If you missed any portion of today's discussion, the full event video is available on thehill.com. Thank you very much. Have a great rest of your day.
Thanks, everyone. Thank you for coming, and thank you for watching.